Hello. For those who don't know me, my name is Michael Antonellis. I'm the Vice President of Marketing and Communications for the Mgfa. And I really hope you're enjoying the National Patient Conference this year, and I hope you're learning some new information that'll help you manage your MG. It is my absolute pleasure today to introduce you to Louis Sokol. Louis is a co-leader for the new Mgfa Caregiver Support Group, and he is a caregiver for his wife, Eleanor, who was diagnosed with myasthenia gravis. Louis is passionate about helping others and passing on his MG experiences and knowledge to those who need assistance. And we're extremely lucky to have him here today to speak about being a caregiver and how we can all support all of the MG caregivers from around the world.
Well, thank you for that introduction. I thank MGFA for having me speak here today. I have been a caregiver for my wife for several years. Here's a just brief bio. She has a number of problems and diagnosed with MG LRP4 several years ago, and we've learned how to deal with it. I live in Washington, D.C. with her, and we have family nearby. And our neurologist, Dr. Henry Kaminsky, who is amazing. And so is our primary care physician, Dr. Jean Beaton, our guardian angel, who works with all of the different doctors that we work with. Everything that I'm saying today, I am not a doctor, although I do have a Dr. Lewis hat that my wife gave me because I sometimes act like one. And so everything here is practical advice from a caregiver's point of view. If you need professional advice, please go to your medical professionals. So here's something that I saw that I just had to show today. And I want to let Sam Masterson know that if somebody gives me $5 million for this, then I'm going to make a substantial contribution to MGFA. So I'll let you know when I get my $5 million. So let's talk about caregiver, or as I prefer the term, care partner. Caregiver seems more like a one-way street, where care partner is an interaction both directions. And so I like the care partner term. So from uslegal.com, a caregiver is someone who provides care for another, generally one who gives assistance to another person who is no longer able to perform the critical task of personal or household care necessary for everyday survival. But there's so much more to it. And the practical definition, I came up with these different facets of what we do as care partners. Emotional support. We have to make sure that they're upbeat and they're not depressed, and they're trying to see how we can just make do with what we have and be positive. Physical support. We have to keep them safe. We have to sometimes add grab bars in the bathroom or do some other things. When we moved to DC a few years ago, instead of our normal bed that we had previously, where my wife is 4'10", she had to hop up onto the bed because it was really tall. Well, the new bed that we got was a low profile bed, so now she can just sit on it and not take a chance on falling. Personal care. I've always done meal prep and most of the cooking for us, but there's some other things that I've taken over and gladly. Medical advocate. I know her medical history. It's here. And when we get questions from doctors and other medical professionals, I can answer that. So that's a big help, because there are times when she doesn't know the answer, or when that particular episode happened, she was in crisis and she has no idea what happened around her. And overall, we're just making life easier for them. So care partner, we know and understand how myasthenia is affecting the patient better than anybody else, including the medical staff. We're looking beyond the numbers to the practical way that they're living. So we know when they get tired, and we know how to help them avoid that extreme fatigue. when my wife is working on a computer or she's cleaning out drawers or something, there are times when I'll say, why don't you leave the rest of it for tomorrow? And she'll know that she's been working really long and it's enough for today. Does she take all her medications on time and the right amount? My wife's very good at that, so that's really not a problem for us. But for some people, that is a problem. What's the mental status? Are we keeping them positive? And I play bridge, and my wife learned to play bridge 40 years ago. And I set up a bridge game where I got involved with her and two other women. And then I bowed out after a few weeks and they had a sub for me. And then I told them, I really don't have time for that. Well, now she plays regularly every Tuesday night with her three girlfriends. And so that's part of the way of keeping her mentally ready and upbeat is making sure she has that thing to do, especially because she can do it online and we minimize the chance of any infections. So what I want to talk about today is how do we recognize when the patient goes into an MG crisis and they have to go to the ER? Because that is so important. How do we recognize this? And Dr. Terralong, your talk was fabulous. And it had so much great information about how to recognize the crisis point and why it's happening and what's going on that we really need to understand, especially as a caregiver, so that we can deal with it better. So the most important parts are the patient may have trouble swallowing. Are they spitting or drooling excess saliva? Are they choking on food? Do they cough more than they usually do? Do they have trouble breathing? And are they shallow breathing and not deep breathing, just like Dr. Terralong talked about? Do they look scared and they know that something is wrong and they just feel different? And you can notice that when you look at them. And so these are serious signals of an MG crisis. So how do we recognize that? Well, I have three things to talk to you about. So first of all, the diaphragm is that muscle under the lungs, and we cause it to go up and push air out or come down and let the air come in, inhale and exhale. It's a muscle. So because it's a muscle, if MG is affecting the diaphragm, that affects how much air we move in and out of the lungs. It's like Dr. Terralong said. So a myasthenic crisis is when you're having that muscle weakness, and that's one type of a crisis. The other one is that cholinergic crisis with too much Mestinon or some similar medication, and it causes a number of other problems. And my wife has had one each of these different types of crisis. So how do we recognize when it's going on? Well, the first thing I want to show you, and this was mentioned before, is the ADL. And we are looking at how we use this as a grading platform for what's their normal. And for my wife, her normal is a score of 5 or 6. And if you ask the patient to grade themselves, and then you as the caregiver grade them also, there's a good chance that's going to be different. Like when I told my wife that she normally is a 5 or a 6, and she looked at where I was giving her points, like ability to arise out of a chair. And she said, well, I'm not a 2. I don't need any help. I said, go stand up. And when she stood up, she had to use the arms of the chair to stand up. And I said, well, try it again. And she needed to use the arms again. She said, okay, I'm a 2. So her first perception would have been a 0, but that's not the case. And so establish what is just the normal everyday number for ADL with the patient. When she was in her normal state of 5 or 6 score, then that was okay. We're living with that. But when she was in crisis, it was all the way up to about 15. And that is a serious change in the lifestyle. And so if you know what your normal is and you see what is it today, and you can see that it's had a significant increase in that number, it's one of the indications that there's a crisis potentially happening. Here's another one, the quality of life or a QOL evaluation. This one is a little bit different. This is more about lifestyle. And so as I typed some of the questions larger because it's hard to read. I'm frustrated by MG. I have trouble eating. I have trouble meeting the needs of my family. I have to make plans around my MG. These are more lifestyle changes, but the same thing. Do a score. Score the patient yourself as the care partner, and then have the patient score themselves. And once you've done this for several weeks, several months, you'll know what the basics are for your normal range. And it's snowflake disease. Everybody's different. Your normal is going to be different from our normal. But once you know that, and then you see that, well, now it's jumped up. Instead of a 6, it's a 10. It's a 15. Now you know things are going on. Things are changing. And you're more aware that you may be headed into a crisis. One of the other things that was mentioned by Dr. Terrelong is that we like to measure more carbon dioxide than oxygen. So the pulse ox test that you do with the finger control measures the oxygen. The way to measure the breathing capability of the patient is with a NIF tester, negative inspiratory force. And so this is one of those NIF testers. We have several of them that we brought with us from the hospitals where the speech therapist or the neurologist had used this with her. And they're very simple to use. So you push in the end of here and breathe in. And then the dial moves to a number. Well, somebody without MG, somebody who doesn't have any severe diseases, can easily pull like 80 or 100 number on a dial like this. Somebody with MG on a good day will do more like 30 or 40. Somebody in crisis is going to do 10 to 20. So that's another good indication that somebody is shallow breathing. They're not able to really clear out their lungs, get rid of that carbon dioxide and replace it with oxygen. So that messes up their blood chemistry. And so having a simple NIF tester, these aren't expensive. They're, I don't know, $20, $30 online. You should be able to get one from your neurologist, pulmonologist, speech therapist when you talk to them about it. And it's a good, handy little thing to have with you because it is a good indication of how their breathing is going. So now that you've determined you do have a crisis, what do? So are you going to panic? Are you going to just not know what to do at all? Or are you going to stop and think, calm down, take a Zen moment, and then think of all the things that you've prepared yourself for so that you can be the proper care partner? So what do you need? What do you have to do ahead of time to be ready for this crisis? You don't know when it's going to happen. They're not scheduled. You can't say, well, next Monday we're going to have a crisis. You never know when they're going to happen. So you just have to be prepared. So here's the things that I would have ready. Do you know where the patient ID and insurance cards are? They're going to ask for it. What are the vitals information? And you can see I have the NIF tester score included in that, and the ADL and the QOL. This may be something that the medical staff may be interested in, especially if they're familiar with myasthenia. Do you have a medical information document? And I'll go into that in a couple of minutes, with 7 or more printed copies, and I'll explain why. Do you have a go bag? with your clothes and chargers and reading material and specialty meds that the hospital may not have, and your NIF tester, because you may want to have this available if the place that you go does not have a NIF tester and they're trying to just do pulse ox. And when you explain how this works and why it's preferred for MG patients, this is something to have with you in case they don't have that. How are you going to get to the ER? Dr. Terrelong explained about using ambulance as an easier entry into the ER, and that's true. But sometimes an ambulance may not be possible. When my wife was in rehab, she was just over the border into Maryland outside of DC. And when she had her cholinergic crisis on a Sunday morning, when I talked to the 911, they said they would have to take her to a Maryland hospital. That no, we want to go to GW in DC because that's where all our doctors are. They said, we can't go into DC. They said, call a private ambulance. So I called a private ambulance service and they said, $600. It's not covered by insurance, but we'll take you where you want to go. And they told them where. And I said, okay, she needs to go like right now. They said, oh, it's Sunday morning. We'll be there maybe 3-4 hours. Well, that wasn't going to work. So I bundled her into my car and I drove her to GW. The funny thing about that was we went up into the ambulance bay where not supposed to go. And the guard said, you can't park here. And I said, my wife's in crisis. They brought a gurney out. One nurse comes around to the passenger side and starts to look at her. The other nurse climbs into the driver's door and leans over to her and said, are you having a baby? And she looks over at him and she says, I'm 68. I don't think so. And so that was very funny at the time. And so they got her into the ER and she got taken care of. But do you know how you're going to go? Do you have to use a friend or family member to drive you? Do you know where to go? That is so important. What if you're on vacation? When we've gone on vacation, I've checked out the local hospitals to see if they have a neurologist on staff. So I would know which one was the best place to go. And then when you're on your way or just before, contact both your neurologist and your primary care physician and ask them to contact the ER that you're heading to so that they can smooth that entry process and make sure you get taken care of quickly. That really helps. And most of all, comfort your patient. A hug, a hand squeeze, let them know that you're there for them and they're not alone. That really does help. So the medical info document. This is so incredibly important. It's hard for the patient to talk about themselves, especially if they're in crisis. You can't expect them to do that. You as the care partner, do you know all that information? And in a time of crisis, can you remember it and quickly and accurately relay that to the medical staff? It's not easy. So if you have a document where they can just read it, that's the best situation. So on our medical document, we've got all of her personal information and the date of this last update. The advocates, myself, our son, our daughter-in-law, who would also know a lot about her in case I'm not available. A short medical history listing the just names of the different things that have affected her, because that's important in their treatment. Allergies and contraindicated meds, the Mgfa list is right here at this conference. If you go into the room where Mgfa has a booth, you can download that right here or get it off of their website. There are a number of great documents Mgfa provides. So all the allergies, contraindicated meds, the doctors, listing the whole suite of doctors that she goes to with their names, their contact information, what their specialty is. And so that way, if the hospital doctors want to find out more about the medical history, that's who they can contact. And also, if our doctor tries to call the hospital doctor, they're more likely to take that phone call because that name is in front of them. Previous meds with notes about good or bad experiences. Oh, so important. There are some medications my wife is allergic to and had a bad reaction, like a rash. And so we marked on there, don't give her this particular medication because it caused a rash or hallucinations or something else. So it shouldn't be tried again. Find an alternative. And so that's something that's hard to remember. But once a doctor or other medical staff can just read that on your sheet, it works out so well for you. When we've shown that to medical staff, they always say, oh, I wish everybody had something like this. So now back to the crisis. Take a deep breath, calm yourself. As you go through the different stages of this, take notes because it's all going to be a blur later and you're not going to remember individual pieces of it that you may find useful to know. Where you went, who you talked to, contact information. And like your primary care doctor or neurologist may want to know exactly who you spoke to, what's that contact information, write it down. So I've got an app on my phone that I use to record all of this information at the hospital. And I have several different entries for the different times we've been to the hospital. And so we can go back and review them because even just a few months later, let alone years later, you're not going to remember the good information that you really want to know. So let's talk about the emergency room players. When you get there, there's so many different people to work with, and you really should know as a care partner what their roles are and how you should work with them. And this will smooth the whole journey through the ER and the hospital. So the EMTs, if you decide to call the ambulance, then they're going to want to know what's the basic problem and what do they need to know to treat this patient. And so if you have that medical information document, then that really helps. And so give them one. They may give it back to you after they read it, but if they want to keep it, that's okay. When you get to the ER, then you may go straight into the ER, or you may get dropped off to talk to a receptionist first, the point of entry at the ER. Or if you're just going yourself into the ER without the EMTs, then you're going to talk to the receptionist first. So what are they going to look for? Well, the first thing they ask for is your ID and insurance cards. So do you have those? You're going to need them. And what you want to do is start the mindset with the ER that your patient is in crisis and really needs to be seen quickly. You need urgent care. And the way that you can accelerate that is telling them, here's a patient in Myasthenia Gravis crisis. Don't say MG because they won't understand that, but say Myasthenia Gravis crisis. They have trouble breathing and they need urgent care. And request immediate triage. Hopefully that will get you seen a little bit quicker and move through the process instead of waiting for a long time in the waiting room. So now you talk to the triage nurse, and they'll take vitals and they'll ask about the patient history and what's going on. Give them the medical information document because that's got the quick summary for them to look at. They may have the one you gave to the receptionist, or they may need a different one. So this is why you need multiple copies. Tell them all about the problem and what you've noticed and why you've brought the patient to the ER. And then tell them when they take the pulse ox test, by the way, pulse ox is not an effective test for a myasthenia patient, and please do a NIF test to complement that kind of information. If they don't know what a NIF test is, hopefully you brought your NIF tester and explain it to them and let them do that test so they get that information for subsequent people who'll be working with the patient. When you get to the actual exam room, then now you're going to have more involved things go on, taking blood and uh, and really talking with a more engaged set of people who are taking all the critical tests at the beginning, but also setting up what they're going to tell the resident and the doctor for further treatment and how quickly the patient needs to be seen. Is it immediate care, or is it something that could wait till some other people go first? So again, tell them there's a breathing problem or swallowing problem, and you're requesting urgent care and to get to see the doctors right away. Show them the NIF tester, explain why that's important if they're not familiar with it. Give them the medical information document. Maybe it's already on the clipboard from the previous people. If it's not, give them another copy of it so they see that. That will help you to get the patient seen quicker. The next step is trying to convince them to talk to the pulmonology department, the neurology department, the speech therapist, and have them consult with the ER doctor if the ER doctor is not familiar with myasthenia gravis. And they need that other information if they're not really familiar with it. If you have the Mgfa brochures, how to work with the ER, the contraindicated medications, you should have that in your go bag. Then hand that to them so that they can put that in the patient chart, and that will help to have the medical staff use that as a guideline for how to proceed safely and not cause additional problems by just not understanding that certain things are harmful to the patient. Then when the resident comes in, then explain again the situation. Ask them if they have experience with myasthenia gravis patients, and let them know here's this medical information sheet with all of the allergies and previous treatments. If they've been in crisis before, tell them that and what was successful in bringing them out of it. Are there other complicating situations like Crohn's and kidney disease, things like that, that my wife happens to have? That's important for them to know. And again, that medical information document summarizes that so they can quickly see everything that they need. And they'll ask their own questions. And for the whole staff, always be respectful of what they do. That is so important. If you're respectful and you're asking questions instead of telling them what to do, you're going to get much more cooperation, and you hopefully will be able to stay there with your patient. Now, with COVID these last couple of years, a lot of times they haven't allowed the advocate, the family member, to stay with the patient, and they take the patient back to the exam room by themselves. Well, then they're missing out on the medical history and other information that the care partner can let them know. So what we did was my wife always had her phone with her, and I'd tell the nurse that was bringing my wife back to the exam room, have her call me and show her where my number was when the doctor gets there, so at least I can talk directly to the examining doctor in the exam room and answer his questions about her history. That was a godsend to be able to do that, because I knew things that they needed to know and not guess at. And so I would always suggest make sure that you have two phones there so that you can do that kind of thing in case they don't let you back into the rooms. If they let you back, that's not necessary, but it's important to have that contingency really handled. And then the attending doctor at some point will come in, and the attending doctor is the one who's in charge of everything. So find out, do they have myasthenia experience? And if they do, that's great, because then they'll know what's effective and they'll be familiar with NIF tests and BiPAPs and IVIG and other things that can be successful in breaking that crisis that they're showing. And so you just need to know, is this somebody that already understands how to work with MG? Or do we really have to insist on neurology consult or a speech pathologist or somebody else that can help them to do things the right way? So these are all the different players that we deal with in the emergency room. And then at some point, they go up to the regular room. And so that's when they're out of danger and they are stabilized. So now they're going to go up and get treatment. And that could be several days, it could be several weeks before they can come home again. So now you have to start over again with who are the players in the hospital room. Well, let's start with the nursing staff. So the nursing staff is somebody who's important and too far. And you have to explain the kinds of things that are going on so that they understand it. They do most of the care during the day for the patient. So they should understand how myasthenia works and that they're tired. Maybe they're a fall risk and because of the muscle weakness. So they should know that. Then talking to the attending doctor is, again, crucial so that you set up the plan of care that's going to happen for the patient. Again, those medical info documents are really important so that they can see at a glance all the different things that are wrong and make sure that they're treating the patient the right way to get them out of crisis and back home safely. So ask them if they would like to connect with your primary care doctor and your neurologist. If your neurologist is at that hospital, then that's a real help, and they're probably more willing to talk to them. If they're not a member of that hospital, they may or may not want to talk to your neurologist. But if you talk to your neurologist, maybe if they called, then they can talk to that attending doctor peer-to-peer and explain more of the background that they know about for your patient. And the more that they talk about that, I think the better off everything will end up. So the hospital reality check. So are the medical treatments, the tests, are the goals set so you know what's going to be done and how long the patient will be there? What's going to signify the improvement such that the patient is getting better and can go home? Or what's going to signify the other direction where things are not progressing like you would like to see and they're not going to go home as quick? Talk about this with the doctors so that you can see, are they doing the right thing? Is there something they've skipped because they're just not familiar with myasthenia, but they haven't taken the time to talk to the neurologist? And that's where you really need to make sure that the neurologist does get involved, whether it's your neurologist or another one. So hospitals are amazing places. And the technology, the treatments that have come about are just so far more advanced than what we saw even just 5, 10, 20 years ago. But problems can still happen. And as the care partner, you need to be aware of the kinds of things that can happen. Sometimes there are contraindicated medications for myasthenia or for allergies or something like that that the hospital has to be aware of. So one time my wife was in the ER and she had infection. And so the nurse came in to give her an antibiotic. And we asked, what antibiotic is that? And she told us the name of it. We said, she can't have that. She's allergic to that. And the nurse said, well, the doctor ordered it, so I have to give it. We said, no, she's allergic to that. You can't give that to her. It turned out that when we entered the hospital And we gave them the page of all the allergies. The intake nurse that was copying all that into the patient record missed one allergy line. And that's the particular allergy medication, the antibiotic, that they wanted to give her. Well, because we asked questions, we blocked that so that she did not get that medication, which she would have had hives and all sorts of bad things happen. So we had to block that. Staff changes. Oh, when she was there, and we had a great hospital doctor, and he understood about myasthenia, and we went through that with him. He had a great care plan. And then on a Friday, when I went home for the evening, I was coming back there every day. Then go home, come back Saturday morning, and come in. My wife's sleeping. I look up at the IV pole, and there's her saline that they were giving her. But there's a little bag next to it, and I look on the little bag because I didn't know she was going to get any other treatment, and it says magnesium. Oh my God. She's not supposed to get intravenous magnesium as an MG patient. So I called the charge nurse, who's the head nurse on the wing, and I said, I need to speak to the attending doctor immediately. And so the doctor comes in, and I said, why did she get magnesium? She said, well, I looked at her labs, and her magnesium was a little bit low, so we thought we should supplement that with some more. Are you familiar with myasthenia? Not really. And so I showed her all the information, and she said, oh, that was a mistake. I shouldn't have done that. And she admitted that that was out of ignorance, not knowing myasthenia. Well, my wife wasn't severely harmed by that, but I went to our neurologist, who happens to be at that hospital, and I asked him, is there any education that you provide to the other departments in the hospital about things like this, so we could avoid that kind of situation in the future? And he said, that's a good idea. And they developed a document, and they sent it out to the other departments saying, if you're thinking of any of these medications, and this is essentially the Mgfa cautionary drug list, then talk to us first before you administer it, and we'll talk about risk and reward for all these different medications. Sometimes they have to get it, and so you monitor it closely. But sometimes it's not necessary, and there are alternatives that are safe, and so they should make those changes. So I had written on the patient board on the wall, no new medications unless you talk to the neurology department first. And they had ignored that. But, I mean, it was all I could do to help to get them to realize that she's a little bit different, and she needs to have a little bit different care taken. And so, okay, why is my slide not advancing? So the other thing that can happen is other staff changes. The nurses also can change, and that can be a problem. So when your patient ends up going home, then what do you do to make that work a little bit better? Well, you can make sure that, first of all, you are being taken care of yourself, and you are healthy, you're getting your rest, you're doing the laundry, you're eating. You have to be healthy and functional to be able to do your role for your care partner. Make sure you take a walk, you watch some TV, you de-stress a little bit yourself. And then when your patient comes home, hug them. Try and get back to normal life as soon as you can so that they feel better. They've been through a hard week, 2 weeks, month, could be a long time. Try and make them feel at home and do what you can for them. So the summary is be prepared. Have that medical information document and have multiple copies of it. Make 7, 8, 10 copies of it. We hand them out to every doctor that we go to with updates in medication where it's changed, or allergies that have popped up, or some other difference, because they need to know that. Uh, Recognize when your patient is going into crisis and know what to do. Have your go bag ready. Have all the other things ready for when that happens unexpectedly. Know who to call and know where to go. Know what to tell the medical staff. And then keep records of your patient vitals, the NIF test, the ADL, the DOL profiles. Have them in your go bags every once in a while so that you have what the typical is as opposed to where you are now because you're in crisis. So I found in the AARP Family Caregivers Discussion Group a great statement about Care Partner. So the Care Partner mantra is respect your body when it's asking you for a break, respect your mind when it's seeking rest, and honor yourself when you need a moment to yourself. It's hard being a care partner when your patient is in crisis. You have to be ready to do your part by taking time for yourself as you can. If you need a break, ask a family member or a friend to spell you for a while so that you can do what you need to. So thanks to MGFA for letting me speak here today. I'm honored that I was able to do that. And the more you learn, the better advocate and care partner you'll be for your patient. And the more confident you will be to help them. If you want to contact me, louis.sokol@gmail.com, louis.sokol. Glad to correspond with anybody. When I go to MG support groups all over the country on Zoom, I talk with a lot of people and follow up with other conversations. I'm glad to do that with anybody who would like to know more about that medical info sheet or NIF test or any of the other things that I've talked about today. And so I will turn it back over to Dova.
Thank you, Louis, so much. We have just a couple of questions. We went a little bit over, so we're going to do a couple of them, and then we will turn it over to Dr. Green. I don't know if Louis is still, yes, you are still with us. Okay. How do you manage your own well-being as a care partner?
Like I said, I'd make sure I watch some TV. I mean, I would go to the hospital every day. My wife was in hospital or rehab for almost a year. And I maybe missed 3 or 4 days that whole time. At night, I watch some TV. I make sure I have a good meal, do the things that I needed to do, and make sure that I was feeling that I was in good shape myself.
The next question is, how often should a care partner do the ADL evaluation?
Well, at the beginning, I would do it every few days and see what the range is, and you'll find probably a few points of a range, and then after a while, you'll see what your normal is in your case, and then I would check it every just once in a while and see if it's changed. Now, if you're watching the patient and you could see that something is different, like if my wife couldn't get up off the couch and I had to put my hand under her arm to help her to get up, that would be different. And so I would do the whole ADL at that point. So if I notice something is changed, I'll do everything I can to check her. But if it looks like it's the same as normal, then just every once in a while.
Perfect. All right. Well, we're gonna send you the rest of the questions by email, And we
Okay, great.
appreciate your giving us this amazing talk. It was definitely a perspective that I think a lot of people really are happy to hear about. So thank you
Thank
so
you.
much, Louis.
My pleasure. Thank you.
All right. We're now going to go on to the introduction for our next speaker, Dr. Green.
Hello, my name is Amy Peterson, and I'm the project manager for the Mgfa. It is my pleasure to introduce Dr. Erica Green. Dr. Green is the Sumner Family Chair in Neuromuscular Research, Director of the Neuromuscular Clinic, and Director of the Neurology Residency Program at Houston Methodist Hospital. She has clinical interests that include a wide range of neuromuscular disorders, including MG. Her translational research seeks to identify and develop effective therapies that positively alter the natural progression of the diseases she studies. Dr. Green will be speaking about the rare forms of Myasthenia Gravis, an already rare disease. Welcome, Dr. Green.
Hi, everyone. Sorry, we are just having a little technical issue. Dr. Green stepped away for a moment, but she'll be back in shortly. We're going to put up her first slide, and we will wait for her to join us. So just give us a few minutes. Thank you.
Hello, my name is Erica Green, and it is my pleasure to be able to present to you at the 12th Annual Patient Education Conference. I am a neuromuscular specialist in Houston Methodist, and we have a large patient population, and we specialize in the care and the clinical trials of our patients. Today I'm going to be talking about the rare of the rare forms of myasthenia gravis. So I like quotes in my presentations, and one of them is, "Good news is rare these days, and every glittering ounce of it should be cherished and hoarded and worshipped and fondled like a priceless diamond." And the reason why I thought this quote was appropriate is because no matter how common or rare a disease is, to the patient, it's important and it's critical. And every patient should be evaluated and treated as unique and special, because even with the most common of diseases, we see so many different subtypes and different patterns of presentation. So I think before we proceed with the rest of our talk, I think it's important that no matter what kind of myasthenia you have, even if it's common to other people's disease or has some atypical features, that each patient deserves a holistic approach to care that is of high quality. Just for a review of what I'm sure you're already aware of, myasthenia gravis is commonly described as fluctuating weakness, whether it's transient with use at the end of the day or persistent. And the classic description is that it is fatigable. This is a fatigable weakness. Often as the day progresses, as one uses their eyes on the computer, or as they're washing their hair, or just walking around. And when it starts, the majority of patients will present with eye problems, whether it's lid drooping in a third of those, or double vision, and even a third may even present with both. And we actually have a small percentage that really don't describe double vision, but describe a blurred vision. A smaller percentage of patients might not present with eye symptoms, but might present with other symptoms of generalized weakness, maybe difficulty swallowing, choking, slurred speech, or a nasal congested speech. I had one patient who had several episodes of what he described as sinus congestion and pressure in the ears, as well as, of course, weakness using their arms and legs. So one subtype that we often describe of myasthenia is an ocular myasthenia. Because the majority of patients, their first symptom involves eye symptoms, it's hard to tell if a person is going to have myasthenia that involves the eyes, maybe the speech, maybe arms and legs, or if they're going to be the small percentage of patients who only have ocular myasthenia. I will say that it takes time to determine if a patient will have ocular myasthenia. That is myasthenia that only affects the eyes, whether that's lid drooping or eye movement. Because the truth is that even though all patients, the majority of them, not all, may present with eye symptoms, the majority of patients will eventually develop myasthenia, that is fatigable weakness, in other parts of their body, with 70% of them, of all patients who present with eye problems, having disease elsewhere by a year. So it takes at least 2, sometimes 2.5 years of monitoring a patient who only has eye symptoms to safely say you have ocular only myasthenia gravis. So I always caution patients that the surveillance and the monitoring should not change until you and your physician are comfortable that you can safely be diagnosed as ocular or ocular only myasthenia gravis. Like generalized myasthenia, it can occur at any age, and like generalized myasthenia and many autoimmune diseases, it occurs more commonly in females than males. As males as people get older, we do see a higher percentage in males. And similar to all other cases, the general complaint is double vision or lid drooping. It can be in both eyes, but more often than not can be more predominant in one eye, maybe fluctuating between the eyes, either noted after awakening or definitely in the evening at the end of the day. And I always ask patients who present to me, did you have a minor episode months before? Did you have a transient episode of double vision that you attributed to something else? And invariably, there's a percentage of patients who, when they think back, remember a time when they had a transient episode of double vision that just went away months or years before it actually presented. So this is a slide which goes over what I spoke to you about before. Myasthenia gravis is an autoimmune disease, and the majority of patients, no matter what subtype, will present with eye symptoms. Of those patients, 80% will have their symptoms spread throughout their body, what we call generalized, by a year. Usually 1 month after the onset, 20% will have symptoms beyond the eyes. By 6 months, 48 to even 50% of patients will have symptoms spreading. And definitely by a year, the rest of that 80% will have generalized symptoms. And this table is showing time in years. You have 0 to 0.5, 0.8 to 1, 1.1 to 2 at the bottom. These columns represent males in the crossed lines. In the checkered pattern, you have females. And you see that the percentage of patients with generalized, most of them generalize. Again, this is between 0.4 in 1 year and 1.1 year in 2 years. So you see that if a patient is going to generalize, most of them will do it within 2 to 3 years after onset of symptoms. It doesn't mean after 3 years that you're absolutely, there's absolutely no risk of generalization. It's just far less. So another aspect of myasthenia that we need to discuss is a myasthenia gravis crisis. This is something that we see in generalized myasthenia. We don't see it in ocular myasthenia because ocular myasthenia only affects the eyes. But a crisis is a risk that can occur in 15% of patients in their lifetime, to the point that they need to be connected to a breathing machine or a ventilator, because the myasthenia can also affect the muscles of the diaphragm, the muscles of the rib cage, which are important for breathing. This is why all patients need to be monitored, evaluated, and treated according to their symptoms regularly, and to be educated. And that's one of the reasons why we're here today. The crisis is defined as breathing weakness to the point that the patient needs to be admitted and or supported with a ventilator, whether that's a BiPAP or an AVAPS, which is the sleep machines that similar to what obstructive sleep patients may use, or even at times being having a tracheostomy or even a tube down the throat. We call that invasive ventilation. And it can occur suddenly or progressively over time. Often patients feel worsening weakness throughout their body, fatigue, may have difficulty controlling their secretions, clearing their cough. And so these are the signs that we're very concerned about, and it's important to include this in this presentation. I'm sure you've already heard it before, just so you understand what symptoms might be of concern. So I'm going to continue my discussion about just an overview of myasthenia, and then we'll talk about some of the different subtypes. Myasthenia gravis, as you might have already heard, exists 15 to 25 cases exist at any one time per 100,000 persons. But we see a little less than 1 to 1 case per 100,000 persons a year. As I said, the majority of patients will present with eye symptoms, up to 85%. But at the end of 2 to 3 years, only 10 to 15% will only have eye symptoms, ocular myasthenia, and the rest will be characterized as generalized myasthenia. It can occur at all ages, but we see the highest peak occurring in the third decade, mostly in females. And then as the population ages, we see another peak in males during the 6th and 7th decade of life. Again, for the most part, this is an autoimmune disease, and females have a greater incidence of this, especially when they're younger. But as we get older, we see more men, and often men more than women. So hormones may have something to do with it, as it does with other diseases. So now let's talk about myasthenia and its history and how our understanding of the disease has developed. This is a quote that has been used a lot by Thomas Willis. He had one of the earliest descriptions of a myasthenia gravis patient in the 1600s. And this was described as a chronic disease. And at the time, they noted that 70% died from breathing failure, usually within 1 to 2 years. And so I have under my charge a prudent and honest woman who for many years has been obnoxious to this sort of spurious palsy in her members, but also in her tongue. She can speak freely or readily enough, but after she has spoken long and hastily or eagerly, she is not able to speak a word, but becomes mute as a fish. And so for medicine, the art of medicine is observation and exam. And we can see that this description, although the way it's described is different than our present American English, really does describe what patients experience and what we see in the clinic or hospital. But myasthenia has many faces and presents in many different ways and progresses in many different ways. It's not just one disease and one presentation per one patient. And so there are many aspects of the disease which dictate how it presents. There may be some genetic factors, and we'll talk about the different antibody subtypes for the disease. So a lot for me for history is very important because it's the historical discoveries that sort of explain how we get to where we are today. So we heard the quote from Dr. Willis, which was in the 1600s, but over the 17 and 1800s into the 1900s, and then we get into the 20th, obviously in the 21st century, we had a progressive discovery of what was behind myasthenia gravis. There was thoughts that there was something circulating in the blood. There was a female physician in the 1930s, Mary Walker, who suggested there's something in the blood mediating this. And then we started to see it in children born to mothers with disease, so something transmitted in the blood. But it wasn't until the 1960s and 70s that we began to say there may be an immune issue here. The immune system may be part of this process and might be affecting the skeletal muscle. This is a teased muscle fiber. What you see is one muscle fiber, this pink longitudinal structure, skeletal muscle. This thin line is a nerve fiber, and this black area is the neuromuscular junction. It was in the 1960s and 70s when the research started targeting this area as the place of the disease. But it wasn't until the 1970s, my mentor, Stanley Appel, who was still active at myasthenia gravis, he, along with Dr. Alleman, Dr. Andrew, discovered that not only was it a circulating immune protein, but that it was an antibody. It was an antibody which was interacting with that nerve-muscle interaction called the neuromuscular junction. And They did this through a group of experiments, which I won't go into, but suffice it to say, this is a fiber of frog, I believe, and this is the neuromuscular junction where the nerve terminates, and they found that antibodies from patients would stain this part of the muscle, and that's how they localized it to the skeletal muscle. Then, of course, we have wonderful pictures, high magnification pictures of the nerve muscle junction in patients and in compared to patients without the disease. This was performed by Dr. Andy Engel. And a high-powered microscopic picture, you see with a normal patient that this blob here is the end of that little tiny nerve I showed you in the previous picture. And in this nerve are bags of chemical called acetylcholine. And normally when the nerve is activated, they release into this space and they interact with these receptors or gates called acetylcholine on this muscle. And you see the muscle looks like a series of peaks and valleys. This is normal. But in myasthenia gravis, the immune system is attacking these dark structures, these gates, these receptors. And it literally disrupts the architecture and the anatomy. You don't see the dark staining. That means the receptors are destroyed and spread out. And this is the reason, because of this change, that the muscle becomes weak with use or time. And so historically, many therapies were used. The first thymectomy was done in the 1900s. They started combining it with thyroidectomy and started noticing improvement. Dialysis was used. But it wasn't until the Korean War where MASH units were developed and we started utilizing ventilators in active acute care and ICU care that the survival rate improved for myasthenia gravis. Once they determined that it was an antibody autoimmune disease, we started employing immunotherapies, plasma exchange in 1979. And now we have greater than 10 and an increasing number coming of therapies that are now targeting the immune system and have totally improved the outcome for the majority of our patients. So in the last couple of pictures, I talked about the nerve muscle junction. I talked about generalized and ocular. So if the immune system is relevant, then what is the protein? What is the problem? Well, as discovered in 1974, the immune system is basically creating antibodies, which are targeting proteins on the muscle. And these proteins are very important for your muscle to respond, those receptors, and activate. The majority of patients have an antibody against the acetylcholine receptor, which is on the muscle. That was that dark stain I showed you in the previous picture. But a smaller percentage of patients who do not have these antibodies, the acetylcholine receptor antibodies, have another antibody against another protein. And this is called muscle-specific kinase, or Musk. An even smaller percentage of patients have antibodies to another protein, which is also involved in successful nerve-muscle communication, called lipoprotein receptor-related protein 4. We love long names, called LRP4. And we see this in less than 6% of patients. But even with all of our different antibodies that we can detect, there still remains about 10% of patients who are negative for all of these antibodies, yet have myasthenia gravis. And it's important that just because you may or may not have an antibody, if you're a seronegative patient, it doesn't mean you don't have myasthenia gravis. It often means that the tests and the assays that we use to test for the antibodies are not sensitive enough to detect one of these three antibodies. And so just if that's a question for you. This is another level of how myasthenia gravis has different subtypes. It can be divided between ocular, generalized, but it can also be categorized based on the antibody status. Which antibody is associated with this disease? As well, we know that for many patients who have the acetylcholine receptor antibody subtype here, a large percentage of them also have an activation of a gland underneath the sternum called the thymus. Now, the thymus is a primary immune gland, very important in developing your immune system as a child. And by the time we're young adults, we don't need the thymus. You can't find it. However, in a greater than 50 to 60% of myasthenia patients who have acetylcholine receptor antibodies, we see that the thymus is activated again. It's proliferating again. But this time it's associated with creating an immune system which no longer only attacks what's foreign, but now attacks something that belongs to you. It attacks self. It attacks a protein on the muscle. We see most of these enlarged or activated thymuses in young individuals under 40 or 50. And we see a smaller percentage, 10 to 15%, of not thymic overactivity or enlargement, but an actual tumor, and typically males more than females after the age of 50 or 60. There are some other antibodies that we commonly see. We're not really sure by science that they're causing the disease. They just may be, extra markers that we find. But we know that those with acetylcholine receptor, muscle-specific, and lipoprotein-related antibody are associated with disease. And the thymus problem we see often in patients who have the most common type, acetylcholine receptor. We do not see thymus pathology in patients who have Musk. And I think there are case reports of possible association with this more rare antibody, but again, it's seen commonly with acetylcholine receptor. So how do these different antibodies make the different types of myasthenia different, and how are they alike? So this slide is a dynamic slide, but I can't really get it to animate. Let's see here. Maybe I could get a little help. Okay, so this is an animated slide, and it actually had pictures that will not come up. Oh, I see. Thank you. Thank you so much. So this is a patient who has Musk-positive myasthenia gravis. Again, this is not the most common type. This is seen in about 15% of patients who do not have the acetylcholine receptor antibody. And we see this more so in women than men, although we do have men. And the reason why this picture is so important is you see the weakness of her smile. We've asked her to smile. And so Musk-positive myasthenia, we see more in females. Predominantly, we see more facial, mouth, neck, and shoulder weakness. We can see it in the most common type, which is acetylcholine receptor, but we see it much more significantly in patients with Musk. Often, they may have a greater risk for myasthenia gravis crisis and may have a risk for more permanent weakness of the face, where even when they're improved, they may have some slight to moderate weakness of their facial muscles, even when their disease is stable and well managed. As well, Musk-positive myasthenia patients respond to many of the same treatments as the other subtypes, but may be a little less responsive, a little bit more difficult, or not as much of an improvement. Again, there's no absolute rule for everyone, and the thymectomy is not indicated. So this is just a sort of complicated slide. This really is to show that for patients who have acetylcholine receptor positive antibodies, we do not see Musk. We do not see patients with both. And that for patients who don't have acetylcholine receptor antibodies, this is just a stain of muscle with serum or antibodies from patients. And this is a patient who has Musk positive, who is acetylcholine receptor negative and Musk positive, and it stains the muscle membrane. And this is blood from someone who doesn't have any antibodies, and it doesn't stain. So these are very specific antibodies. We don't see them as false positives. Musk is not associated with other diseases. So what is Musk? And I think I'll just go on here. So Musk is very important for how the acetylcholine receptor is organized. This slide is a little busy and it doesn't really translate the way I'd like it to, but suffice it to say that the acetylcholine receptor sits on tops of those hills and valleys of the muscle, like a chia pet, if you remember that reference. And Musk is a protein, and you can't really see it here, but Musk is a protein which is very important here for sort of clustering these acetylcholine receptors on top of the muscle, sort of aggregating them together. And when Musk is not working or is absent or is destroyed, these acetylcholine receptors spread out on the muscle, and so the muscle is less excitable because you need these acetylcholine receptors clustered together. And when they're not, you don't get great nerve muscle activation. I apologize for the sort of the animation I had planned. It just is not translating, but I hope you understand what I'm explaining to you. And I'll go on. So we know that when mice, these are experiments, when mice are given antibodies from patients with Myasthenia Gravis, they're actually weaker. So this blue line is a mouse walking, okay? And he's been given antibodies or serum from a patient without myasthenia in the blue, and he's learning how to walk, he's gaining weight, he's going faster. In the green is someone who has been given, a mouse who's been given antibodies by a patient who had acetylcholine, and you see there's a change in their mobility. And then you see this red line is a mouse given antibodies from a Musk patient, okay? And what we know is that Musk is very important for nerve muscle transmission, but maybe not only affects the muscle, but may actually also affect the nerve. And I'll go on. And so how does Musk Myasthenia Gravis and acetylcholine receptor Myasthenia Gravis compare and contrast? So I've already told you that Musk Myasthenia Gravis, we see a lot more of face involvement, especially it affects more females, even more so than acetylcholine receptor. And it even can affect the neck muscles as well and shoulders. Both the acetylcholine and the Musk have lid drooping and eye closure problems, but it may be more predominant in acetylcholine receptor. Again, there are no absolutes. We often see atrophy and even some permanent weakness of the face and tongue with Musk, but we'll often see limb, eye muscle weakness. And in patients who've had myasthenia for a very long time, such as teenagers who have acetylcholine receptor, we may see eye muscles or shoulder muscles or hip muscles that even when they're at their best are persistently weak. The Thymus pathology we see in the acetylcholine receptor subtype with hyperactivity or even typically a benign tumor, rarely a malignant tumor in older individuals, we do not see with Musk. And although the risk of crisis is there for both, it seems to be a higher risk for Musk, but I don't want to confuse you and make you think it's not a risk for the other. You still need to be educated about the signs and symptoms and have a plan. The one thing that's different about Musk is that we all have different antibodies. And our antibodies, we all have different types of antibodies. And there's a whole population. And for acetylcholine receptor positive, it's an IgG1, IgG3. What does that mean to you? Well, that's the majority of autoimmune diseases. But there's another subtype called IgG4, which is what Musk positive myasthenia gravis patients have. And the reason why that's important is because there may be treatments that are better for IgG4 antibodies, such as Musk, than for the IgG1 or 3, which we see with acetylcholine. And just a little bit about LRP4. What's important from this picture, without confusing you, is that acetylcholine receptor, Musk, and LRP4 are all interrelated in making sure that the muscle responds to nerve stimulation. So basically, Musk protein makes sure that the acetylcholine is aggregated on the muscle, and the LRP4 interacts with the Musk protein. So all three of them are important for muscle function and muscle hyperexcitability. And now we know that antibody destruction of each one of these disrupts that. This is also a slide because we're talking about why myasthenia is the rare of the rare diseases. And the reason why it's the rare of the rare diseases is because in general, compared to stroke and heart attacks, it's rare. But because there are different subtypes categorized by ocular generalized, characterized by different antibodies, characterized by whether or not there's thymus disease or not, but also there may be some genetic issues that determine why some people get myasthenia, some people respond to therapy, and some don't. This is not a slide that you need to memorize, but this is just a list of some of the genetic determinants which might predispose to autoimmune disease. And these are called HLA haplotypes. And sometimes certain gene arrangements in these genes predispose us to different diseases. And there are certain ones that predispose to autoimmune disease, including myasthenia gravis. We are not testing these normally because the yield or how it changes our management doesn't change yet. But as a patient and as a community, it's important for you to know that we are doing the research and learning why even though 10 people may have the same disease and may even have the same antibody, there are other factors which may dictate why someone responds or presents one way versus another way. So we talked about immune therapy. This is just a slide to sort of remind you about the history of that. But what it's led to is a whole list of different agents that we can use for all of these forms of myasthenia that I've mentioned to you. Mestinon increases acetylcholine between the nerve and muscle. It doesn't really treat the immune attack, but what it does is it allows the muscle to respond. Then you have a host of immune suppressant therapy from prednisone. And I'm not going to go into detail about these therapies because I believe Dr. Gil Wolfe is going to talk about it, to Imuran, cyclosporin, Cellcept. All of these medicines are targeted to calm down your immune system, to decrease the number of those antibodies, or to wash them out, such as in plasmapheresis. We also have newly FDA-approved treatments, including Soliris, and our most recent one through Argenex, which Dr. Gil Wolfe will talk about. And then there's a role for thymectomy as well for those patients who have thymic overactivity. So, long story short, as I was mentioning, the history is important because as we discovered that there's something in the blood in the 1600s and 1800s and 1900s, when we discovered that this is an immune disease in the 1960s, and then as we discovered that it's actually an antibody for the majority of patients, acetylcholine receptor and now other proteins, we've been able to tailor our treatments to improve survival. This is a table showing the death rate in the 1900s, which was nearly 100%. And this other yellow line is a line representing the number of treatments and interventions that increased over time. And it shows you that the death rate decreased to less than 10%. Now, presently, it's at 3 to 8%. So we've made huge advances based on our discovery, and we're continuing to make those advances. So I just wanted to talk about the role of autoimmunity. because this is what myasthenia gravis is. I just want to remind you that we've talked about ocular and generalized as one category, how it's further categorized by the types of antibodies, by whether or not the thymus is involved. And also there may be some genetic determinants that put us more at risk for myasthenia and other autoimmune diseases. Myasthenia is one of 100 different autoimmune diseases, and often it may run in families, and often our patients have more than one. So I like this slide because I think it's important for you to understand the immunopathology. Normally, when we are exposed to a virus or a bacteria, we get sick. Our immune system is there to detect it, like the military, and to take it out. So this represents the antigen, bacteria, virus, cancer, and we have sentinels, watchmen of our immune system ready to attach, to sample this, and to say, and take it back to the camp. And basically, if we use the military analogy, the immune system alerts your immune cells, your T cells, your white cells, and they generate an attack against this antigen and destroy it. Okay? And once this T cell or white cell, I call him the general, is activated, he begins to recruit and train other T cells, which then bring in the infantry, and they start developing antibodies to destroy that bacteria or virus. Sometimes they send in snipers called cytotoxic cells, which actually just take out the foreign material. So that's normal. That's normal. And then we also have other cells that after we're done fighting that virus or bacteria, calm down the system so that we can go back to normal. Now, in autoimmune disease, what happens is those immune cells are not just attacking viruses and bacteria, they're attacking proteins that belong to you. And so I like to use the military as an analogy. Your immune cells, those T cells, the problem begins in development. Often the T cells are trained normally to be able to tell self from non-self. But in autoimmune disease, something happens and they're not trained well. So instead of fighting COVID or bacteria, they attack acetylcholine receptor, they attack Musk receptor, they attack LRP4, and they cause problems. And this is just a cartoon saying the same. And so the thymus gland is where the basic training occurs, and possibly the hyperactivity of the thymus is a marker of poor training. And so this is a CT showing an enlarged thymus underneath the sternum and even a benign tumor in an older individual. And you see it's very active, lots of cells. In myasthenia gravis, whether it's the acetylcholine receptor or the Musk, the T cell is activated against that abnormally, and it recruits infantrymen who create antibodies or arsenals to attack those receptors. They may even bring in Scud missiles, I call complement Scud missiles, to destroy the Musk and the acetylcholine receptor. But unfortunately, the cell that calms it all down is not strong enough to do so. So the immune attack is ongoing. And so this is a cartoon showing you have your nerve terminal, you have acetylcholine, it connects with the acetylcholine receptor. The Musk is keeping that receptor at the tops of the heels. This is normal. This is normal. However, and this is just a picture showing how the Musk, the LRP4 work together, keeping the acetylcholine clustered together. And that's a normal nerve muscle picture. I've showed that before. In myasthenia gravis, these antibodies are coming from white cells and they're attacking these acetylcholine receptors. And this is the destruction. And in Musk, it's attacking the Musk, doing the same thing. So that's why immunotherapy helps and makes such a difference. The thymectomy trials show that in patients under the age of 45 and 50 benefited from the thymectomy 1, 3, 5 years after the thymectomy, requiring less prednisone, less Imuran, and less plasmapheresis and hospitalizations. And so this table really shows the evolution of therapy and what we've acquired even up to this year with the approval of our recent drug. So I'm going to end now by talking about just a little bit about opportunities, because we now have identified not only the general principle of disease for myasthenia, 1970s, we identified one antibody. Now we have 3, maybe more antibody subtypes. Now we know about other proteins in the immune system which are relevant, such as complement, such as other antibodies, such as other proteins. Now we have an idea about the genetic modifiers. And so that has allowed us to develop therapies which are precise and specific and are making such a significant impact on how patients do. And this is what this diagram shows, that of this military arsenal of T cells and B cells and proteins, that we now can select and create therapies that are specific targets against specific cells, specific proteins, without as much side effect as what you might have with steroids or other drugs. Again, this is not a slide for you to memorize, but just to take away that because we're understanding myasthenia and its rarer subtypes and its more common subtypes better, we can tailor therapy more specifically. And this is just a table listing all the medicines that have been studied. We have eculizumab, which has been FDA approved, and more recently we have efgartigimod, which is a receptor blocker for immunoglobulins against your muscle proteins, which has recently been FDA approved. And I suspect we're going to see a flurry of newer medications coming down the pike, because we are identifying that myasthenia gravis is not just one disease, but is multiple subtypes of a rare disease. And so this is just a diagram showing that there is more research to be done and new drugs are being identified. So I think it's very important that although this is a rare disease, and even among the subtypes, some subtypes are more common than others, but it is a wise man who said that there is no greater inequality than the equal treatment of unequals. And what that means to say is that as we're learning about myasthenia, that it is a rare disease compared to most diseases, its subtypes may even be considered more rare. And it requires us to understand the disease in a way to precisely create targets and to develop precision medicine that takes into account the subtypes, the age, the genetics, the antibodies, and the specific proteins involved in the disease for one person, which may be different than for another person. I thank you for the opportunity to present my talk, and I'd be happy to take any questions.
Thank you, Dr. Green. That was a very informative talk. The first question that I have is, are any of the new therapies, either the ones that are just out or the ones that are coming out, going to be effective for seronegative and Musk patients?
So that's an excellent question, and I'm going to say likely yes. Efgartigimod, which is it's called, oh boy, there's so many different names. Vyvgart, potentially has the ability to treat seronegative patients. It's not FDA approved for seronegative patients, but because it targets antibodies, and it doesn't matter what kind of antibodies, it just targets the sort of turnover of antibodies, that it potentially can benefit even patients who are seronegative but are felt to have myasthenia. And I think that there are going to be more drugs like that coming along. We still need to study it in seronegative, and the FDA wants more information about that before they approve it for seronegative. But I'll say that with more study, there might be an indication, at least with this drug and those coming down the pike.
Okay. And because I know we have a lot of patients that, everyone's super excited about the new drugs that are coming out, and the seronegative community and the Musk people are, get a little disappointed that they won't have those options. I mean, they might, but they're just,
Well, I
it's
think it's more than
disappointing.
it is disappointing, and I don't think you should be disappointed. I really think, because most of us in the community are very excited, and we're excited because we have to go through the process of clinical study. We have to go through the process of FDA, and the FDA approves drugs for your safety. And so the studies have to say, okay, you showed it in enough acetylcholine receptor positive patients, but in order to make sure that this is safe for everyone and effective, we need more of this patient. As a clinician and someone who's done science and research, I can tell you that in terms of its mechanism, hypothetically, it should work for seronegative patients. But in order for us to get it to you, we need to prove to the FDA with enough patients that it will. So I think it's stronger than it might. It's just us pushing the science, which we're doing.
Great. Thank you. The other question we have is, and this is going to be the last question, is MG inherited or genetic? If I have it, will my children get it?
So autoimmune myasthenia gravis, that means where your immune system is attacking, causing the problem, is not inherited. However, the genetic predisposition, which I mentioned in my slide, might run in families. A predisposition does not guarantee disease. That means that someone is more at risk for it. And so often in those families, someone may have rheumatoid arthritis, someone may have myasthenia, many of our patients have thyroid disease. It clusters in the family because there's a genetic predisposition. So your children are not guaranteed to inherit myasthenia from you, but just like diabetes and other diseases, they might be at greater risk for autoimmune disease, including myasthenia gravis.
All right. Thank you very much. We appreciate your time today. And if we have any more questions, if anyone sends them in, we'll send them your way.
Thank you.
Thank you, Dr. Green. Thank you, everyone. We have a short video right now, and then we're going to go to a break. Thank you.
When we did a virtual walk in 2020, who would have thought we'd have to do another one in 21? So we're going to go around the yard, and the kids are going to break the barrier. Off we go, into the wild blue yonder.
Follow Grandpa.
Yay, Grandpa! Off we go.